We are live, ma'am.
Hello everyone, I'm Dr. Rajeshwari, Clinical Head and Fertility Specialist, Oasis Fertility, Banashankari Unit, Bangalore. Today we'll be discussing about endometriosis and fertility. Now, before speaking about the endometriosis, I would like to explain a little about the normal menstruation so that it will be easy for us to understand how this endometriosis or endometrioma develops. I'll just tell about the anatomy: uterus, cervix, vagina, the opening of the fallopian tube into the uterus. These are the two on either sides of fallopian tube. The ovaries, from where the egg will be formed. And this is the endometrium. Every month, under the influence of the hormones, that is the estrogen and progesterone, this lining develops, gets ready to receive the baby. Once the fertilization occurs in the tube, the embryo which is formed comes back into the uterus and gets itself stuck or implants in the endometrium. This is the lining which will help in the implantation and growth of the embryo. This goes on for about 3 weeks. It develops itself for about 3 weeks. If there is no pregnancy, the hormone support which is coming from estrogen and progesterone will reduce. Once it reduces the support to the endometrium, it shrinks and breaks down. This endometrium breaks down and comes out as menstrual bleeding. This has got a passage, so it comes out through the cervix and vagina as the menstrual bleeding. Some amount can also come through this opening in the fallopian tube and fall outside in the pelvis. This is the normal menstruation, and the body recognizes that menstrual blood which has fallen outside in the pelvis, that it is something not normal, it's something abnormal, and usually it takes it out, doesn't let it stay there or grow. Now, coming to the definition of endometriosis. What is endometriosis? It's a painful disorder where the tissue which is, the tissue which is lining the uterus grows outside the uterus, that is over the ovary, here, tube, uterus, and other places. Usually it is seen in 2 to 5% of the women in the general population, and in the infertile women, a little more than that. Somewhere up to about, studies have shown that 25 to 50% of the women who are having difficulty in conceive can have endometriosis. At different stages it can be, they may be having symptoms or no symptoms, and for any other cause, if we do a laparoscopy, we may find mild endometriosis. That is the reason why he has given such a wide range. 25 to 50% of the infertile women can have endometriosis. How does it develop? Now, I was telling you how the menstruation happens. When it comes out of the tube, endometrium, when it comes out of the tube and falls over the ovary in the pelvis, that is over the ovary or the tubes, on the uterus or behind the uterus, intestine, over the bladder, anywhere it can fall. Usually the body recognizes something abnormal and removes. Sometimes for whatever reason, the immune system may not be functioning properly, so it may stick there and start to grow under the influence of the same hormones which is supporting the lining to grow inside the uterus. So every month the lining of the uterus has a passage to come out, so it comes out through the cervix and out of the vagina. But here, which has fallen over the ovary, just one example I'm showing, over the ovary, it has fallen there and it is implanted there under the influence of the hormone which is supporting the lining of the uterus in the cavity. This supports it, this also, and it grows there. It doesn't know that it will not get an embryo to support its growth, but it grows there under the influence of the hormone. When there is no pregnancy, the hormone level comes down and the breakage of the endometrium happens and comes out as menstrual bleeding. But here, there is no passage for it to come. It breaks down and it stays there. And it goes on collecting here over a period of months and years. So initially, it may be a small size like a mustard. Then gradually, it starts growing to a marble size or orange size as well. That's why I've shown that it's small, a little bigger, and this. What happens is the blood has got water part, that is the fluid part, and the cells as well. The cells remain there, but the water part is absorbed. So the cells remain there, and over a period of time, it becomes very thick. And it becomes like a tar, like a chocolate, very thick. So it is also called as a chocolate cyst or endometrioma. It keeps growing, and when it is formed here, it can cause lot of adhesions. See, you can see here adhesions, the intestine, the ovary, everything can come together and stick together. So the exact, how does it cause? Why does it cause? What is the reason for it to develop, for any one woman to develop? We do not have any definitive or one particular reason to say, scientific reason to say this is the cause for the development of the endometriosis or endometrioma. There are series of theories which are said and nothing is proven. One is the retrograde menstruation. What I was telling, some amount will come out of the tube and fall on the pelvis, on the ovary tubes and all. That's called as retrograde menstruation. That could be one of the theory. Another one is faulty immune system, because the immune system has to recognize that it is something abnormal and take it out. So there may be some fault and it may not recognize that there is something abnormal and I have to remove. Or it could be genetic as well. What I mean by saying genetic is, we see this endometriosis in some families. That is grandmother, mother, aunt, or elder sister. Somebody will be having. And we have seen in certain regions also of particular region where many women from that region will have endometriosis. So it is told that there could be genetic inheritance as well for the development of this endometriosis. Another thing is, it can get transported through the lymphatic system, or one more thing is Mullerian theory is that in the fetal life itself, this endometriotic cells have been put in a different places and they start to develop after puberty under the influence of the hormone. So there is no one definitive theory to say, yes, this is the cause for the development of the endometriosis. And now coming to the common sites, I already have told, but I just want to show it pictorially. See, it has come out, it has fallen on the fallopian tube, ovary, uterus, vagina, and there are many other places like intestine, lungs. I do not know, maybe that lymphatic theory will explain how it goes to the lungs and other places. And then it can be seen also in the scar, where you have a cesarean scar or any other scar, it can get implanted there, grow, and this women will complain that every month when I have my period, I have pain here, some swelling comes. So it gets implanted in that scar and it grows there as well and causes pain for them. That is the operated scar, bladder, intestine, uterus tubes. And how do these women come to us for the doctors to say? Their main symptoms will be pain. Some people can have pain during periods, the 1 or 2 days earlier to period, during period, and 1 or 2 days later also. So there is no fixed pattern to say this is how the endometriosis will present with pain. So they can have dysmenorrhea. It can start 1 or 2 days or only during periods. It varies from women to women. And some people can have following intercourse, what we call it as dyspareunia, because of the endometriosis which has implanted in the pelvis, which is growing there. When they have intercourse, they can have pain, deep pain they can have. Some people can have discomfort when they open their bowels, when they pass their motion, what we call it as dyschezia. They can have a little bit of bleeding as well. They say typically that when I have my periods, I have bleeding in my motion as well. And then another thing is, some people can have pain throughout the month. There is no particular relation to the period. They'll say continuous pain, low backache they will be telling. And some women can present with difficulty in conception as well, infertility. How do we diagnose? The main thing is history taking. A very good history taking is very important for this. About the pain, when does it come, how long it stays, and any relation to the period, what she does, where is the that history, that whether they have anything associated with passing the bowel while passing. Some people even do say that when they pass urine also during that period time, they pass blood. So a very good history, whether they have pain during intercourse, all this needs to be taken, which will help us in suspecting probably this is a case of endometriosis and how to go about. Next step is examination. What do we do during examination? It's a general physical examination, but typical or very particular for endometriosis will be vaginal examination. When we do the vaginal examination, certain findings will be there. That is how the uterus is, whether she's having pain, whether any nodules we can feel. All this will give us clue towards endometriosis. And another thing, next step is the imaging. Imaging is Best is transvaginal ultrasound. This transvaginal ultrasound will tell us only about the cysts in the ovary, that is endometriomas. It cannot tell anything about the peritoneal implants or other nodules. So for that, we may need to do MRI also, or even laparoscopy. That is invasive it is. Laparoscopy, we don't do MRI for everybody, only when it is severe and we are planning for surgery or we are suspecting that kidney and ureters are also involved. That is when we do an MRI to diagnose it, to say, okay, how do we manage this case? Then laparoscopy, it is, we do not say everyone should undergo laparoscopy. It's only for very few people. That will serve as a diagnosis as well as operative. At the same time, we can get the view, see how severe it is, and operative. That is, sometimes there can be adhesions. Due to that adhesions, the uterus tubes, ovary and the tubes can be pulled together along with the intestine, all behind the uterus or anywhere it can be pulled away. Tubes can be pulled away from ovary. So even if ovulation is happening, egg is released, but it will not be picked up by the tube because it's nowhere near the ovary. So all that can be corrected and try to bring the pelvic anatomy to near normal anatomy. Why is it difficult for the women to get pregnant? As I told, adhesions, that is, the tube is pulled away somewhere, ovaries go away somewhere, and then intestines and all can get stuck behind. That is, the tubo-ovarian anatomy can be disturbed. And it can also have effect on the motility of the tube, which can be affected. Even though it picks up the egg, it may not be able to have a good motility that to transport or the transfer the egg or later formation of the embryo to get into the uterus. Another thing is ovulatory disorder. Well, that is about the tube, one thing. Second, coming to the ovary. What happens is there can be disorder in the egg formation itself, one thing. Second thing, it can affect the quality of the egg. Third thing is it may not release the egg at all. Luteinized, unruptured follicle is what we tell. That can happen. Another thing is the endometrium itself, the receptivity of the endometrium itself can be affected. All this can happen due to the inflammatory reaction which happens due to this endometriosis per se itself. It can affect the quality of the egg, tubal motility, adhesions, and then endometrial receptivity. It can also have the effect on the luteal phase, that is the phase where after the embryo is formed, it supports the embryo to grow further. That also can be defective, and that also can contribute for the lady or a woman to get pregnant or continuation of pregnancy in these women who have endometriosis. There are stages. 4 stages usually done based on the laparoscopic finding or operative finding. There's a scoring system. It depends on where the lesion is, what is the size of the lesion, whether it is deep, superficial. We give a scoring and we tell it is minimal, mild, moderate, or severe. Severe and moderate are the extreme end. Minimal and mild can be there, and women may not know at all, and we do surgery for some other reason, and we may be noticing it that time, and we may stage it as minimal or mild. And there is no correlation between the woman's symptom and the stages. Sometimes what happens is some women may have extreme of pain and they may be not able to do their daily day-to-day activity. They may be only having a very minimal endometriosis. Some women may have severe or moderate endometriosis where there is everything, lot of adhesions, all the anatomy is distorted, big endometriomas are like 6-7 centimeters, and they may say, yeah, when we ask them and we do a scan for fertility issue or something, do you have any pain? They will say, yeah, a little pain I have, doctor, during my periods. Or then we have to ask a leading question saying, do you have pain also when you have intercourse? Yeah, sometimes I have a little pain. So there is no relation or correlation between the stage of the disease and the woman's symptoms. And then what are coming to the treatment? What kind of treatment is there? Both medical and surgical treatment are there. Medical is women who are not trying for pregnancy. We can just, and they have mild pain during their periods, we can just give them analgesics for 1 or 2 days and they can manage with that. And there are certain hormones as well. like progesterone, oral contraceptive pill, or it can be some injections which can reduce this. Some hormones will reduce the hormone imbalance, and so the periods will come regular, but small amount of bleeding happens, and the pain can be controlled by that. Pain reduces, and there are certain hormones, injectables as tablets as well as tablet. They stop the period. The reason behind giving that is to prevent this endometrioma or the endometriosis progressing further. When we give those hormone medication, what happens is women can have certain side effects like hypoestrogenic state. They may be having a lot of sweating, mood swings, dryness of the vagina, and they can also have effect on the bone mineral density. That is, it can reduce. So we may not be able to continue it beyond 6 months, the treatment of this medication. And mainly these medications are given for women who may not be wanting to have fertility. They may be just wanting to have symptom relief. For them, it will be ideal, because these medications will not increase the fertility per se as such for these women who want to get pregnant. The next thing is the surgical treatment. Surgical treatment, it can be laparoscopy or laparotomy, that is open surgery. Both can be done, but laparoscopy will be preferred because it is minimally invasive, and women can get back to her work, shorter stay in the hospital. Within a week or so, she will be back to her work and she can be quite normal. And we can do the same adequate work as we do in open. What we do in this laparoscopy is we stage it. Second thing, we can get back the anatomy, remove all the adhesions can be released, and cystectomy, or that is removal of the endometriotic cyst, and ablate the spots, means to say burn the other spots, so that the endometriosis, that mass can come down, and it may help in conception. Or the cyst drainage. When we say cystectomy and cyst drainage, you may ask me what is the advantage and what is the difference. Cystectomy is we remove the whole cyst, that is we peel the cyst wall. When we do that, advantage is that recurrence rate will be less, or it takes a longer time also. The second thing, or the disadvantage of that, is when we do a cystectomy, when we peel the wall of the cyst, some amount of eggs also get lost, because the eggs will be spread over the cyst wall. So their egg reserve can come down. That is a disadvantage for a woman who want to have fertility, means who are concerned of the fertility. Cyst drainage is the women who are trying for pregnancy, we can do that, or their egg reserve is less and they want to try for fertility. We do not want to lose the eggs. For them, cyst drainage and little bit of cauterization, and try for pregnancy as quickly as possible. Give them some hormones which can suppress the whole or dry up the endometriotic spots or the disease, and then we can go forward with the fertility treatment. And for these people, before laparoscopy also, we can give them certain hormones which can suppress this endometriosis. It helps, but what happens is, one thing is it can dry up, and with the staging means to say we may not be able to see it to that extent. We may think it is a milder stage, even though it is a severe, and one, blood loss will be less. The other thing is to peel or to clean it, or to clearing may be a little difficult as well. Then coming to women who want fertility treatment, how do we go? See, there are many factors which needs to be taken into consideration before we start off with the treatment. What does the woman want? Fertility means what is her age of the woman? How long she's been trying, that is duration of the infertility. What are her symptoms? What is the scan finding? Is it a very big endometrioma or a small one? That also comes into consideration. Then tubal patency. Is her tube, fallopian tube, open? Have we checked her tubes? Then another thing is the male factor. Is the semen parameters of the husband normal? All this has to be taken into consideration, and individualized treatment. Her staging is also very important. We need to know whether it is a mild, minimal, mild, or severe form of the endometriosis. And then we can individualize the treatment for them. Now, coming to the age of the woman, if she is younger age, maybe married only for 1 or 2 years, and they have come for pain or any other incidental finding, and we find just 1 or 2 centimeters or 3 centimeters endometrioma is there, for them we can give something simple treatment and help them to conceive as naturally as possible, like give them for ovulation induction and monitor them, make sure that they ovulate, and during that time they can have timed intercourse. If not, we can give them medication so that they produce more than one egg, not more than three, 1 or 2, or maximum 3 eggs, not more than that. And we can time it and do an IUI for them. Take the husband's semen sample, process it, bypass the cervix, and put it into the uterus and do the IUI. If the woman is more than 35 years, and even if it is mild or minimal type, if she is unable to conceive in 1 or 2 cycles of IUI, maybe IVF will be the better option for her. Or if there are tubes are not working, or the semen parameter is not, even if it is mild, moderate, mild or minimal, then also it would be ideal for them to go for IVF. And for women who have stage 3 and 4, that is moderate to severe endometriosis, their best option would be after the clearance through laparoscopy to go for IVF ICSI treatment. Why I said laparoscopic clearance is, if it is more than 4 centimeters or it is coming in the way of taking out the egg, the ovaries are pulled away, it may not be accessible for us, or for removal of the eggs. In all these type of cases, we would like to do laparoscopy, release, make those ovaries accessible for us to pick the eggs during IVF and go ahead with the treatment. That is better. And why I'm saying for stage 3 and 4 or more severe and moderate and severe stage of the disease to go, best option would be IVF ICSI is because in these stages, endometriosis is recurring. As long as you don't get your period, it can dry up. But once you start getting your period, you may go for surgery. You may have 1 or 2 medications where 1 or 2 months you don't have period. Then you will say, I want to try on my own natural for about 6 months or 1 year. You're back to square one, because every time you have your period, these severe or severe endometriosis will recur. Most of the time it recurs again and again. So you will be back to square one again. They'll all the ovary tubes, whatever you had done through laparoscopy release, that will be back to the adhesions, and you may have difficulty again conceiving. And repeat surgeries are not easy for this endometriosis because the intestine and all will be stuck. There can be chances of damage or perforation of the intestine. So it is not good to have repeated surgery again and again. Once you have a surgery, you know it's a severe stage, you are trying for pregnancy, it's best, whatever method, to go and get pregnant. That is the best option. And every time you have a surgery, the egg reserve also starts to come down. Then coming to fertility preservation. See, women who have severe endometriosis are at risk of having premature ovarian insufficiency. Their egg reserve may be low. That is the low AMH, what we say. And surgical treatment, when we do repeated surgeries, second surgery, third surgery, the egg reserve further comes down. For such kind of people, oocyte cryopreservation can be offered, but it comes with its own pros and cons. So it's always best to explain them what is the advantage of it, what is the disadvantage of oocyte cryopreservation. First, let me tell you the advantage. Best is to give the good news. Good news is, if at all her egg reserve is coming down and she doesn't have the plans of getting pregnant in the next few months or 1 year, she wants to delay it for 2 or 3 months. Most of the women want to delay pregnancy because they want to pursue their career and climb their career ladder. So they will keep postponing. For them, if they come back after 2 or 3 years and already at diagnosis her AMH or the egg reserve was low, maybe cryopreservation will give her a chance to have a biological child, her own child, biological own child. The bad part of it, not bad, I would say the cons of it, side effects or the bad part of it is, one is expensive. It's an IVF treatment, though you're taking your eggs and freezing them, it is expensive, one thing. Second thing is, you're taking so many injections, vaginal aspiration will be done of the eggs under anesthesia. So you're exposing yourself for anesthesia. However minimal risk is that we have to give the woman all the what to say, procedure advantages and disadvantages and help her to make the decision. That is one thing. Another one is there is no guarantee that you will get pregnant with those oocytes, with the same eggs, because freezing the eggs, there's some studies say 80% of them can be recovered, means to say they survive. And about 40% pregnancy is they say, but not all studies say that one. So we do not know what is the facility available where you are undergoing. So that is one thing you have to know. And then not all eggs will survive. It has got its own risk and it is expensive. It is something like keeping a deposit in your bank and saying, yes, I have some money. There is there for my what to say, times when I have difficulty. That is when your egg reserve has come down and you're unable to conceive, and you have your own eggs when you were younger, 2 or 3 years younger, or 4 or 5 years younger you were when those eggs. So chromosomally normal eggs and having your own biological child chances are high. And now I have covered whatever I could cover under endometriosis, and I want to say that what is the message at the end of my talk? Endometriosis is a recurring condition. In case of severe or recurrent endometriosis, fertility plan needs to be done as the ovarian reserve can drastically reduce. Women older than 35 years with severe endometriosis have a better pregnancy rates with IVF and XE. Fertility preservation is in cases of severe or recurrent endometriosis should be recommended in selected women only. Thank you. Any questions? What is the treatment for endometriosis? Treatment for endometriosis is stopping the periods. That is the main treatment, because as long as you don't get your period, there will be no progression. But how long can we stop the period? We can only stop with medication for about 6 months, or else you have to undergo surgery where you will remove your uterus and the ovary. Stopping your periods basically is the treatment for main treatment, permanent treatment, what I mean to say. And other treatment is medical and surgical, what I have told already covered in the talk. What are the symptoms of endometriosis? That also has been covered, but I'll come over it again. That is, one is they can have pain during periods, before periods, or pain throughout the month. There is no relation to their periods. The pain can be present throughout the month, low backache. Then they can have dyspareunia, that is pain during intercourse, and they can have infertility, that is difficulty in conceiving, or when they can have discomfort on passing motion, opening their bowels. What age does endometriosis usually occur? There is no fixed age. Anytime after your menarche, we are seeing even in adolescent girls. So in reproductive age women, this will be seen. What is the main cause of endometriosis? We do not have one, solid reason to say this is the cause. There are many theories, but none of them have been proven to be scientifically proven that this is the cause. Blood can come out of the tubes as normal during normal menstruation, and the body does not recognize it as an abnormal thing and does not remove. So that can be one. Hereditary, that is genetic cause, also can be one another cause. Is there any stage of endometriosis? Is there any stages? There are 4 stages: minimal, mild, moderate, and severe. Depending on what we see inside during laparoscopy, then we have got a numbering system. Depending on that numbering, where we find how deep it is, how big it is, we give it as stage, that is 1, 2, 3, 4, that is minimal, mild, moderate, and severe. What will happen if endometriosis is left untreated? Nothing will happen if you don't treat endometriosis. We are only treating, if she's not trying for pregnancy, we are only treating her symptoms. She doesn't have any symptoms. Many of them, as I already told, it doesn't correlate. There is no correlation between the symptoms and the stage. So women may not even be aware till she is 4-5 centimeters or 6-7 centimeters of endometrioma. She may not even know that she has endometriosis. Somebody may have just one small spots here and there, less than 1 centimeter endometrioma. They may be having severe pain, and that may be having effect on their daily day-to-day activity as well. So nothing is going to happen. You can leave it most of the time. You can leave it unless it is very big and it is pressing over your bladder, bowel, and you are having problems. And the chances of cancer is also very, very minimal. Cost depends from institution to institution. So wherever you're going, you have to, for the treatment, you have to go and discuss with that. I do not know what you mean by the cost, whether you are asking for the cost of the fertility or you're asking for the laparoscopy. So it varies from institution to institution. So you have to go to the institute where you're going to get the procedure, whatever procedure done, you have to find out from them. Thank you.